Hello, everyone, and welcome to today's Cochlear Center seminar. My name is Shannon Smitherman, the staff host for today's meeting and Senior Academic Program Coordinator for the Cochlear Center for Hearing and Public Health. Today's speaker will be Dr. Larry Hume, and he will be presenting on an approach to the measurement of auditory wellness in older adults. Today's faculty moderator will be our Center Director, Dr. Frank Lin, who will lead our session and monitor activity for any questions you may have. Before we begin, I would like to share some ground rules for today's meeting. Participants should be muted upon entry. Please stay muted throughout the seminar. If you have any questions you would like answered by today's speaker, please use the active chat feature that will be monitored by our faculty moderator, and only panelists can see what is sent in the chat. The seminar is live captioning is not being offered for today's seminar, but will be available for future seminars. The recording will be posted on the Cochlear Center for Hearing and Public Health website, and the recording will include a full transcript of today's presentation. If you're experiencing technical difficulties, please contact Jamie Trumbo, and her email is jcheng33@jhmi.edu. All right, so now I'm going to turn it over to Dr. Lin.
Hi, good afternoon, everyone. And I want to thank all of you for taking the time to join us for this Cochlear Center virtual seminar series today. We're really thrilled to have Dr. Larry Hume as our monthly seminar speaker. Dr. Hume is actually scheduled to be our in-person speaker back in March of 2020, just as the pandemic began, which was unfortunately canceled, but we're thrilled to be able to bring him back in a virtual way. This is our second seminar of the year. Last month we had Willa Brenowitz from UCSF join us. Dr. Hume speaking today. Next month we have one of our local speakers, Dr. Cujo, who's one of our geriatricians at Hopkins, followed by Nicole Maroney in January, Sharon Inouye, expert in delirium research from geriatrics at Harvard, joining us. And finally, to cap off the end of the year in April will be Shelley Chadha, the director of the WHO World Hearing for the Hearing Program, as well as Audrey Rennie, who's executive director of a nonprofit delivering hearing care service around the world. That's our virtual seminar series. I'll also note briefly too that, and events details we posted later is on March 29th of this year or next year, we're doing our annual Cochlear Center Research Day, which used to be an in-person event. That'll be virtual. It'll be an all-day event headlined by Brett Rutherford, who is a geriatric psychiatrist at Columbia University. Could we go to the next slide, please? So I want to introduce briefly now Dr. Hume, who for any of you on the seminar today, I see 67 people attending right now. Any of you in the hearing sciences, I think Dr. Hume doesn't really need introduction. I think there are probably a handful of people in the auditory hearing science space that everybody knows, and Dr. Hume is one of them. So we're absolutely thrilled to have him today. Dr. Hume received his Ph.D. in audiology from Northwestern in 1979, and then really began his academic career at Vanderbilt until about 1986, when he then later became a professor at Indiana University, later becoming the director of the Division of Audiology, and then also then the chair of the Department of Hearing and Speech Sciences. Dr. Hume's research, which you'll talk about today, really over the last 20 years has focused a lot on perceptions of hearing and speech and noise, particularly for older adults, which you'll discuss today, and we'll hear his insights. Larry, I want to really thank you again for being willing to join us virtually today. For all the seminar attendees right now, there'll be a chat box. You're welcome to post questions throughout. Some that I might be able to pose during the talk. Otherwise, we'll have an open session at the end where I can pose the questions for you, or you can also we can also unmute you if you raise your hand. For the Cochlear Center trainees, I think all of you are aware, after the session with Dr. Hume today, there'll then be a separate room where you'll have a more informal discussion with Dr. Hume beginning at 1:15. So at this point, Larry, I'll let you go ahead and share your slide and begin. Thanks.
Great. Hopefully that looks good on your end. Title slide. Thanks very much, Frank, for the opportunity. Extended originally, as you said, back in March before the whole world changed. And it's I'm glad your perseverance was adequate enough to hang in there and invite me back for another chance at it. So I appreciate it. I'm looking forward to it. And as Frank said, the topic is aging and auditory wellness. And I have a joint appointment currently. So I'm Emeritus faculty at IU, and I'm also on the faculty at Northwestern University as well. Just as an outline then of today's talk, I'll go through very quickly because I know this is familiar content to everybody most likely on the call in the webinar. The prevailing disease-based approach to age-related hearing loss, or ARHL, then transition to looking at a wellness-based approach, and then finally the prospect of empowering older adults to manage their own auditory wellness. So we'll start with the disease-based approach. It's been known literally, for centuries that as people age, they lose hearing in the high frequencies. And it's so well standardized that these are ISO standards for median hearing loss in males on the left and females on the right by decade, 30 through 80. And we see steady progression of hearing loss primarily in the high frequencies. And so this has been well documented for a long time. And the typical profile for older adults is bilaterally symmetrical sloping sensorineural hearing loss. And from that audiometric information, there have been various ways to categorize the severity. This is the original WHO system that dated through 1991 and had a range for normal hearing, slight impairment, moderate, severe, and profound, based on the pure tone average at 500, 1,000, 2,000, and 4,000 in the better ear. And so it was based on the audiogram. And it's been revised since. In the original version, it was only this moderate impairment that was considered to be disabling hearing loss. So that was when basically the idea was that's when the onset of real difficulties begin, or everyday difficulties. And then the boundaries have been redefined lately by WHO, and so they've been lowered for these categories of normal, mild, and moderate. But it's still the case in the most recent recommendations that disabling impairment does not begin to start until this moderate degree. And that's entirely based on the pure tone audiogram, with some implications for functional performance noted over here on the other column. So quantifying the audiogram allows you to then estimate the prevalence of hearing loss. These are some data from N. Haynes that Frank and colleagues published, almost a decade ago. But its prevalence of hearing loss is a function of decade from 50 all the way up through 80 years of age. And as we know, prevalence of hearing loss increases with age. There also are large-scale studies, and that's what I'm trying to focus on as much as possible today, or large N samples wherever possible. But in terms of hearing aid use by older adults, this is from the epidemiology of hearing loss study, the Beaver Dam Cohort, with 1,460 roughly individuals, showing whether they ever, the dark bars, or currently use hearing aids, the gray bars. And as you can see, hearing aid use increases by age decade. And that's true over here in the N. Haynes sample. Again, Frank is a co-author of this paper as well, showing the same pattern and their differences between men and women. And overall, this overall estimate from the Beaver Dam Cohort isn't that much different from many of the others, in showing about 10% or so that are currently using hearing aids, and a larger percentage, maybe 15% or more, that have ever used them. So we know that hearing loss prevalence is much greater than that. Only a small portion of those who could receive help are using hearing aids. And this is a compilation of international data. So the prior story was for US data primarily, but this is a compilation of statistics from more worldwide or international data sets, and using the WHO definition. This is the number of older adults around the world that are expected to have disabling, so at least moderate severity, age-related hearing loss, so over 160 million. And if you look at percentages, now not relying on US data, but for example, the Eurotrack survey of Europe and comparison to other continents, the uptake of hearing aids can be estimated to be a fraction of that, again, about 20% overall. Then those who keep them after they've first acquired them, and those that are satisfied with them is shown here at the far right. And so we see a progressive decline kind of in these outcomes. So few people served, and some of those who have been served aren't keeping or aren't satisfied with their devices. So clearly there's lots of room for improvement in terms of providing devices or treatment to older adults with age-related hearing loss. So there are several different barriers to that, certainly cost, and we'll talk about this again shortly, but affordability and accessibility are the two key factors I think that most people are converging on as to why more older adults aren't acquiring and using hearing aids. But accessibility sometimes is intermixed with affordability, that you don't have access because you can't afford it. But this is another way I think to think about accessibility, is because it's a professional driven service delivery, it's the number of hoops or hurdles you have to clear to get to the end goal. And so this is data from, these are data from Bevan Yu that was actually looking at comparing different screening methods in older adults in the VA. But what I did is basically pooled the data across all the different screening methods to look at what happened in the course of treatment, basically, the natural progression that these people went through. So it's a large N again, roughly 1,400 people. Almost half of them failed the screen, whatever method was used. And then what I want to do is just see what happens at the subsequent steps. And basically what they did is after a year had passed, they looked to whether the person was using the hearing aid, and then they worked backwards to see what happened along the way for each of these people who initially failed the screen. So it was retrospective in that sense, looking back at what events transpired in the intervening year. But only a smaller portion contacted the audiologist. Then still smaller kept the appointment. Then the audiologist decided that only a certain portion had aidable hearing loss. Then a smaller portion actually had hearing aids fitted after they were explained. And then about the same proportion, but still a small proportion, were using their hearing aids a year later. So in the end, of all those that failed, only a small portion are actually receiving the desired intervention. And 10 to 15% of those who failed the screens were successful hearing aid users a year later. And I think this is part of the other aspect of accessibility, is getting to this end and having to go through these steps to get there. And that's the way it is and has been for quite some time in kind of a professional driven illness or disorder, disease-based approach to age-related hearing loss. Age-related hearing loss has largely been considered a disorder or a disease. The first step in the disease-based model is for a professional to identify and diagnose those with the disease, and then a professional to actually implement the intervention, typically in this case involving a hearing aid. And the evidence is that this model has failed to meet the needs of most older adults with poor auditory function. So after decades of it being that way, there was this whole sequence of events over the past decade that I'm sure, again, everybody on the call is familiar with. I think of it starting with the NIDCD working group is providing the impetus for this and identifying accessibility and affordability of hearing healthcare as two major goals limiting the uptake and use of hearing aids by older adults. That was followed on the heels then, the President's Council PCAST report, also supporting improving accessibility and suggested over-the-counter devices as a way to do that. I think Frank chaired this group that resulted in this report from the National Academies, but again, lending support to accessibility and affordability being the issues and trying to come up with alternatives to that, including over-the-counter hearing aids. 2017, the Federal Over-the-Counter Hearing Aid Act was enacted. In the interim, FDA has approved Bose's self-fitting hearing aid, which isn't the same as over-the-counter, but it's another development. And sometime this year, the last I heard, it's been a moving target, but I believe it's the case that the FDA is still expected by the end of 2020 to release draft OTC hearing aid guidelines and rules. So these events collectively have created the opportunity for a self-driven auditory wellness approach to hearing healthcare for older adults. And so now I want to transition to that notion of a wellness-based approach to age-related changes in auditory function. And of course, this is framed around the WHO, World Health Organization's ICF model, where more than just the impairment of bodily functions are considered, it's also the limitations on daily activities or restrictions on participation in society. All those things contribute to the well-being, wellness of the individual. And this forms the basis of the now well-known WHO ICF model. This is an illustration of the general model. Health and well-being is what we're interested in. These are the individual functioning components. This is bodily structures, impairments, restricted activities or limited activities, restrictions on participation. And then there also are contextual factors, primarily environmental factors and personal factors that can impact all of these. I'll work through an example in hearing, but the main thing to point out here is that the audiogram is really just this piece of the puzzle. And there are many other pieces that impact the health and wellness of the individual. Here's an example worked out with the assistance of Louise Hickson. And it's the same categories again, now bodily impairment, activity limitations, participation restrictions, environmental factors, and personal factors as context. But aging, as we saw, can produce a bilaterally symmetrical hearing loss. That then leads to difficulties in understanding speech, listening to television at the same volume. And because of those things, participation restrictions might be that they avoid social situations if it's noisy. Goes in another room to watch television away from the family members. All of these things can be modulated by things like whether he's living alone or in this case with his spouse in their own home, on a pension, does or doesn't have supportive family. All those are contextual environmental factors. Personal factors can be his age, his gender, how mobile he is, whether he has other sensory disabilities. All these things collectively can impact the effect of hearing loss on the individual. And again, only this one is captured by the audiogram. I believe it's possible for self-report tools, on the other hand, to capture all or most of these domains. The other thing point I want to emphasize is that the reason this is important is because it's known that untreated age-related hearing loss has important consequences. And each of these topics listed could be a separate webinar, but we know it's been documented. The one at the top is probably the most well documented in terms of that hearing loss causes problems with speech communication and everyday living. But it's also fairly well documented that there are indirect consequences on psychosocial well-being, probably depression being one of the most frequently studied. And mounting evidence, due in large part to impetus provided by Frank, but mounting evidence about the impact of hearing loss on cognition as well. So untreated hearing loss can have all of these consequences, and so that's why it's important to improve on the current situation and the current model. Yeah, which is what I just said. So, okay, so that's a quick overview of kind of a general wellness approach. Now I want to focus a little bit more on one particular approach. And so most of what I have to say we'll talk about one particular tool that's already available, the Hearing Handicap Inventory for the Elderly. That's this HHIE. I'll have an example, a couple example questions coming up, but this is the screening version. 0 means you don't have any perceived hearing handicap, which I'm kind of doing this as the inverse to auditory wellness. So that if you don't have any perceived handicap, then you have great, excellent auditory wellness. If you're up here at 40, the worst possible score on this scale, that's maximum hearing handicap, that's poor auditory wellness. There are no direct measures that I'm aware of auditory wellness itself. There are measures of hearing difficulties, hearing handicap, hearing problems, and I'm using this scale as basically a reciprocal to auditory wellness. But if we look at group data, again, pretty large N, these are pooled from a number of different sources, and we see a very systematic change with the WHO, the latest hearing impairment grade. So as severity of hearing loss goes up from normal to severe, their handicap goes up. And you'd look at the mean data and say this is a very orderly function. When you look at the individual data relating these two things, a different picture emerges. There is a correlation. It's about 0.62. But for any given hearing loss, in this case, 20 dB, better ear, 4-frequency pure tone average, which would be the boundary between normal and mild, we see people that have maximum handicap and people that report no handicap. Now, this is a little bit misleading just because it's two-dimensional and you can't see additional cases the way this is drawn. So let me just switch to the next slide, and this will better show through this contour plot. But this is the association. So now here is bad or our highest, worst possible HHIE score down here, 40, and no perceived handicap here at 0. So as we go down, handicap is increasing. And then pure tone average is no hearing loss here up to moderate here. And we see this mountain range that progresses along the diagonal so that most people with very good hearing report little hearing handicap. But there is a range from all the way up to, if we take 20 dB as an example again, some people are reporting severe, maximum hearing handicap, and many others no hearing handicap. So it's just an indication that there are individual differences. Some of it, about 36% of the variance, is captured by the audiogram, the hearing loss, but there's a lot of it that's not captured. And so I think that's one of the potentials of these self-report measures. They can be sensitive to bodily impairment, like the audiogram, but also capture some of these things that aren't as strongly tied to the audiogram. And we'll look at what the HHIE in particular measures in just a moment. Another illustration of this that was eye-opening for me is we were conducting this study and advertising for people to come in from the local community. We called it the ABCD study. It was a randomized controlled trial of a way to self-fit hearing aids. But two of the key requirements indicated that we were investigating different ways of providing hearing aids to older adults with hearing loss. So they knew it was something to do with hearing aids. And they were told down here in the ads that they would be required to purchase hearing aids. So clearly they're entering the study knowing that that would be something they'd be required to do, but they could have never worn hearing aids previously. So new hearing aid wearers. And when we look at the audiograms, this is what they look like. In fact, this is just a subset. In the left panel, this shows all the individual audiograms, but it's the best 20% of the 361 volunteers who showed up to have their hearing tested as a part of the enrollment process. They all had normal hearing according to WHO. They're the most recent guidelines from WHO. So better ear, 4-frequency, better ear, pure tone average, less than 20 dBHL. So all considered normal, but I don't think very many clinicians would consider those people to have normal hearing. And just to clean up some of the clutter, these are the medians and interquartile ranges here for the individual audiogram shown in the left. So I think most people, most clinicians would look at this and say, no, they have significant hearing loss in the high frequencies. A hearing aid would be helpful. But these people are in the normal category. And remember, mild and normal are not considered to have disabling hearing loss. They're not considered to have a significant enough difficulty to require intervention according to international guidelines. Okay, so moving now to more information about the HHIE. So what I'm going to talk about is use of this measure as a self-report measure that captures not only bodily impairment, but also some of these other domains of wellness. The reason I chose this is a practical one to some extent, in that it's by far the one that's been used the most. So there's the largest volume of existing data for some version of the HHIE. So it's the hearing handicap inventory for the elderly. It's been around for almost 40 years. There's two versions, full 25 item that includes social and emotional subscales. So the attempt was to quantify those things separately. Most people have found them to be strongly correlated, and I'm only going to talk about the total score when you score all 25 items. But just know that some of them focus on social aspects of hearing handicap and other emotional reactions to it. And then there also is a brief 10-item screener, HHIE-S, that was developed from those 25 items, mainly trying to find the items that would give the best reliability was the criterion, while still keeping about 5 social and 5 emotional items. They're by far the most common self-report measure, the HHIE-S in particular, because large-scale studies are usually pressed for time. They've got a zillion different measures that they're trying to get, not just in hearing, but often in other areas. And so a 10-item screener has a lot more appeal than the full 25-item test. And so anyway, most of the population studies and large clinical studies have used the HHIE-S in particular. And that's what I'll look at first. Here's an example for those not familiar with it. So this is one that has to do with a social problem. Does a hearing problem cause you to use the phone less often? Yes, no, sometimes. And there are 25 items in the full one. Yes is 4 points. So if you said all these things, yes, you had problems, then you'd have the maximum score of 100 in this case. If you said no to all, it would be 0. And this is an emotional item. Does a hearing problem cause you to feel embarrassed? And so it's definitely tapping dimensions aside from just the bodily impairment component, which probably correlates more with the social and less with the emotional components. Okay, so in attempting to look at, find different data sets that had HHIE-S scores, this was one of the samples I could put together. And they reported HHIE-S scores, but just range of scores, 0 to 8, 10 to 24, 26 to 40. And there are one clinical study in red, a VA sample of 2,700 people, and then about 2,700 again that are 2 different population studies, the Blue Mountain study and the Beaver Dam Epidemiology of Hearing Loss study. These had males and females, but because this one was males only, I decided it would be fair just to compare males only throughout this. But you could definitely see clear trends where the population studies, most people didn't report much hearing handicap, and it decreased, and by the very few that had severe hearing handicap. Clinic study, the red, has the opposite trend. So it seemed to be tapping into some of the differences in these samples from this first pass at it. It was also constrained to these ranges because these were the cut points used by the HHIE-S for screening purposes. So these scores were designed to give you HHIE-S results that agreed best with pure tones. So the idea was, can we use a self-report measure that would tell us what pure tone audiometry would as to whether they could hear or couldn't hear? Well, to me, it's almost like which one's the gold standard. In this case, they were using the self-report measure as an attempt to match the gold standard, pure tone audiometry, because that's what they were trying to use it as a substitute for, a screening tool for hearing loss. But if you think of the self-report measure as being broader and capturing more, then the fact that they don't agree is actually informative, because the self-report measure is capturing more than just the bodily impairment. So what they viewed maybe as a negative, it didn't match up well, could be viewed as a positive, because it's capturing bodily impairment, but also captures these other aspects of function. So there were some studies I could find, and people graciously granted me access to data that now I could look at all of the scores. This is the HHIES on the x-axis. So again, the range of scores is 0 to 40. This is maximum handicap, no handicap. And we have, these are community samples, population samples, and these are 2 in red clinic samples. Oops, sorry. Well, that's all right. I think I can show this way here. So now what I've done is taken those measured percentages. So this was the graph that we just saw, but now this size, and I'm just showing that what I'm calling this likelihood ratio, which is the percentage from the normative samples, the black bars, divided by the percentage with those scores in the clinic samples, the red bars. That becomes a ratio. And when it's normative divided by clinic, it's these black circles. And we can see, just like the black bars show you here, it starts out with a lot of people having very low scores and very few people having high scores. If I go flip it the other way now and make the numerator the red bars, the clinic sample, do this same ratio, I end up with this red set of ratios. And this is just illustrating this endpoint again, where there are many more people from the clinic sample that had high scores of 40 than there were that from the population sample. So this is just a way of kind of distilling this information down into these likelihood ratios for 2 different types of samples, likelihood that they came from the normative population sample or the likelihood that they came from the clinic sample. And just for illustration, these are where the previous cut points were for the HHIES when it was used as a pure tone screener to try to match up with hearing loss. And what I suggest is that what I did visually and then tried to also support with statistical calculations is that this is one region where the likelihood ratio is so great, we have high confidence that you came from the general population, not the clinical population. This still is in favor of this region of scores. It's in favor of coming from the community or population samples. Here it's about a coin toss, 50-50. You could have been from each. And now it reverses to where the ratio is 2 to 3 times greater that you came from the clinic, and then much greater than that here. So I started out visually trying to eyeball some of these breakpoints in these functions, and then also corroborated it statistically, and there's pretty good match with the statistical analysis as well. And I ended up then coming up with labels of auditory wellness for this. If their score was 0 or 2, excellent, 4 or 6, good, 8 to 14, fair, 16 to 22, poor, anything greater, 24 or greater was considered very poor. Exactly what adjectives use. And this is all just, I'm talking about a concept, a proposal, nothing etched in stone, but just trying to evaluate a possibility for a wellness measure based on the HHIES. So now, using those boundaries, going back to the original data set, we see these 4 or 5 categories, and if you have this range, you're mainly from the population sample. Red again are the clinical samples. If you're up in this range, you most likely came from the clinic sample. And so this was based on the HHIES, which is the 10-item screener, and a high N of 12,500 people roughly. I'd prefer to use the more complete HHIE total based on all 25 items. And to be able to do that, I needed to translate scores from HHIES to total. And it's not a simple linear adjust for the difference in the scales. But Judy Dubno fortunately had data from about 1,200 older adults in which she had the raw scores, and you could compute the HHIES on the x-axis and the total score for all 25 items here and map out the relationship between those, and that's the red line. And so now I have a transfer function basically that will let me take the boundaries that we just established from a large sample of 12,500 people and apply them to boundaries or convert them to boundaries for HHIE total scores. And I'll show you why I wanted to do that here in just a second. So basically we translated the 5-point grade range from HHIES scores to HHIE total scores. And so now we can look at some other clinical samples. We had data from 433 people. Judy had close to 1,200 people that I call a community sample. This was a clinic sample. And we can see clear differences again in the distributions of scores. Not surprisingly, most of the people in the community sample had very little self-reported hearing handicap or excellent auditory wellness. And then if we come down here, the likelihood ratios, the difference between these now is much more in favor of the clinic, that they came and had poor or very poor auditory wellness. But by extending it to these studies and the HHIE total, it allowed us to also better validate this measure because we had other self-report measures, other types of data that we could use to compare these different auditory wellness category groups. So one of the things we had in both data sets was whether they were hearing aid wearers or not. And we can see based on their auditory wellness category, as their wellness declines, they're more likely. This is in the community sample from Medical University of South Carolina, Judy's data, and we see a higher prevalence, a percentage that are current hearing aid users as their wellness declines. That's current hearing aid users. In our data, we had ever worn a hearing aid. We also had some data on current, but we asked in this case, had they ever worn a hearing aid? And we see that's increasing steadily as their wellness declines. So that's a form of validation using a different type of data point, in this case, whether they were hearing aid users or not. We also had full communication profile for the hearing impaired scores from these individuals. And if you're not familiar with that, so that's probably the most elaborate measure of perceived problems related to hearing loss and your reactions to those problems. It has 163 items total. If you do the entire thing, 25 scales, 5 factor scores. I'm just going to show you the 5 factor scores, thankfully for you. I won't go through all the other scale by scale analyses, but these are the proposed auditory wellness categories and now excellent, good, fair, poor, very poor, based on this HHIE total score range. And these are the factor scores that emerge from the CPHI. And the main thing I just want to draw your attention to is that for those with excellent auditory wellness based on the HHIE, they also have excellent scores on the CPHI, a much more in-depth, broader tool of problems and their reactions to them. It's a research tool, right? I mean, nobody would do 163 items in the clinic. It's just terribly long, but for a research tool, it gives you a very detailed look at their problems and their reactions to them. Then we go down here, this group's significantly different from that, and all the others, all the way down to the worst group, the very poor, have the lowest function. The only one that isn't affected by their wellness rating is this communication environment factor, which is kind of almost like a arbitrary miscellaneous factor. So for the most part, you can ignore it and just see the steady progression from high CPHI scores to the lowest as we go from excellent to very poor auditory wellness. And again, this is a form of validity, validating this scale against something other than the HHIE from which it was derived. The HHIE is also known to be reliable, which is important if you're going to recommend it as a possible measure. So these are just some data that shows, in this case, by subscale, but that's not relevant. The main thing is that over time, from 7 days after fit all the way out to 6 months after fit, there were no effects of time. It was a very stable measure. And here on the right-hand side, just shows a bar graph of test-retest correlations over many intervals. And the HHIE is this black bar. It's almost 100% of the correlations were in the 0.9 to 1.0 range. It's better than 2 speech recognition measures that were also included in this study. So bottom line is, for both unaided and aided measures, the HHIE, both the screening version actually and the total that was used here, is a reliable measure. So what I've been trying to paint is a picture that self-report measures might give us a more complete picture of auditory wellness. They're correlated moderately with PTA, so they capture that bodily impairment component, but they also capture activity limitations, participation restrictions in the other items that comprise the index. And in particular, the HHIE is a reliable and valid measure of auditory wellness in older adults. Okay, so another benefit of using something like the HHIE, and again, something like, I'm not saying that that's the only answer or the right answer, but it's an example of one tool that could be used to serve as an auditory wellness measure. But the Over-the-Counter Hearing Aid Act emphasizes that the primary criterion for purchasing or acquiring an over-the-counter device is perceived mild to moderate hearing loss, not audiometrically measured mild to moderate hearing loss, but perceived mild to moderate hearing loss. So that's just blowing up that part there. And it also allows for the possibility of self-assessment of hearing loss as one of the tools that could be used. So the HHIE lends itself beautifully, or something like it. Why use the audiogram that may not be as closely tied to perceived difficulties, but use a tool that directly measures those perceived difficulties? So the focus is shifting away from a clinical disease-based system to a consumer-empowered self-assessment wellness system. And in addition, the lines are blurring between conventional hearing aids, hearables, and consumer electronics, with a focus on auditory wellness and enhanced participation in society for adults, including older adults. So it's an ideal time to be transitioning to wellness and over-the-counter devices that can be acquired directly by the older adult. I'm getting close to where I can wrap up here. Just to give you a heads up, I'm aware that I'm getting close to the end time here. I want to allow enough time for questions. But this is, again, the study, this ABCD study, where we recruited new people into the study. But I just want to look at this in a little bit more detail now. So first, again, I had those audiograms all superimposed for the top 20%. This shows audiograms categorized differently here into the mean audiogram for those in the WHO normal category, the WHO mild category, the WHO moderate. And this is the ISO 70-year-old, the filled circles, ISO 70. And so we see a steady progression, but even the people in the normal category have significant high frequency hearing loss that many people would think is amenable to treatment with amplification or otherwise. If we look at their self-reported, in this case, the full HHIE score for these 3 categories, there's almost no difference. There's no significant difference, but even descriptively, there's not much difference. And all of them would fall in that 5-point scale as poor, meaning even the people in the normal category self-report that they have enough difficulty, no different from those in the mild and the moderate self-reports. And then in terms of benefit, so we have black bars here as unaided HHIE total, gray, light gray is the aided, and then the relative benefit, the difference in those is the rightmost bar in each panel, the dark gray, and the horizontal lines show you that basically they're all reporting on average the same amount of benefit, those in the normal, mild, and moderate category. So even people in these categories that aren't considered by WHO to be disabling hearing impairment, who volunteered for the study, never having worn hearing aids before, can get significant measurable benefit and reduction in their perceived difficulties with hearing aids, not unlike that by the mild and the moderate groups. And this panel is 77 people who self-fit their own hearing aids, and it's really no different from these that had audiology best practices. So you can get these positive outcomes regardless of the audiometric category that you're in, even with a self-fit approach. Finally, this would probably be a good place to quit after this one. This is looking at, so in this study, before they were told what group they were in and debriefed about the study, they said, are you likely to keep the hearing aids at that 6-week point? And that's the black bars. And these are the percentages that said they're not likely to keep them. And ultimately, they could have them, they could opt for audiology best practices if they wanted, or they could keep what they had. But ultimately, we could count up how many ultimately returned their hearing aid. That's the gray bars. And the point I just want to emphasize is that even those in the normal category, 20% returned their hearing aids, 80% kept their hearing aids. So that's another, a very proving, I think, outcome measure is they paid for them and they ultimately kept them. It was worth it in terms of what they paid for the devices to keep them. And sure, it's not the same as slight, mild, or moderate in terms of the percentage that were kept, but it's still 80%. And if you put this in, sorry, let me skip this. I just want to get to put that in context. Sorry. Just close your eyes for a minute. Whoops, this is one. Okay, so now if we put this in context of, okay, this is that original international tabulation of data, 162 million people in older adults in the world with disabling, at least moderate hearing loss. What we're trying to, this is the current status, how many uptake hearing aids. We're trying to capture this 80% who currently aren't getting help because we know that untreated hearing loss is not good. And if it's even the case that only half of those people opt to keep their hearing aids, then we're talking about this kind of gain in the number of people served. And so, you know, you could look at it and say, well, it's not 100% that are keeping their hearing aids or showing positive outcomes, or even if it's just 50 to 60%, which is more in line with what we've observed, that's still cutting into half of the population that currently is not served by the model. And so we're going from maybe, looks like 30 million to 105 million people that would benefit. It's certainly not here up to the full 160 million, but it's a vast improvement. So I think I'll just stop there and still leave at least, looks like 10 minutes or so for questions.
Larry, thank you so much. And on behalf of everyone, you can't hear the applause, but I'll applause briefly. And thank you, Larry, for a really, really insightful and illuminating talk that I think brings up a lot more questions than answers, which is a good thing if you ask me. So I wanted to pause here now, and I see a few questions in the chat, which I'm going to read off. But I invite anyone at this time now to please ask questions in the chat, which I'll read off. If you'd like to ask a question yourself, that's fine as well. Just notate that in the chat and/or raise your hand through the in the chat feature, and I can call on you. So I'm just going to go in order here. John Swen, who's one of our trainees at the Cochlear Center, he asked Larry, specific regard to the WHO International Classification Function Model, which you presented earlier. What are your thoughts on domains that are not addressed or captured by the items on the HHIE? Or are there any domains you feel like you feel it's adequately captured, or are there things you think are glaringly missing that HIG does not capture? Yeah, so now it's a good question, and just so everybody's on the same page here, sorry if I can pick it up. Yeah, so I don't think there's any, well, short of maybe the 145 item CPHI, I don't think there's any one metric that captures all of these domains, but I'd say the HHIE is pretty good about
Well, I'm saying this because it's moderately correlated with bodily impairment, hearing loss. So I'm saying that I think it's sensitive to that part, and it's framed around both activities and participation. So participation often includes emotional reaction of people to it, and activities is more social often is the way it's framed. And so I think these are the two strong points of the HHIE, but it also taps or is correlated moderately with this. So I think it does a pretty good job, but it doesn't, the CPHI goes through a lot of detail of, you're seated at a table with, it goes through and examines a lot of these environmental and personal contextual factors that aren't treated here. So there are some measures, but it's this trade-off between the complexity and length of the tool and what you are able to measure. But I think the HHIE does a pretty good job of this, but not so much with context.
Thanks, Larry. Larry, we have another general question that it's basically building something you said before, how the PTA to some degrees explains the variance in the HHIE scores. And the question is, do you think there's a role of other types of diagnostic tests, let's say specific tests of auditory processing disorder or other central auditory measures of functioning, that may better explain the correlation or between the PTA and the HHIE? Namely, what other metrics could be used to basically better account for someone's self-reported functioning?
Yeah, no, that's a good question. All I can say is that there's a moderate correlation. So kind of to me, so that the correlation's about 0.6. The test-retest correlation for the HHIE, either the screener or the full one's about 0.9. So if you square those, kind of what people would think of as the systematic variance, 0.9 squared is 81%. It is systematic variance, it's not error variance. And about 36% of that is explained by hearing loss. So that leaves 45% to account for. But I don't know, I'm saying, it's, you're right. I mean, it could be, there could be cognitive issues, there could be central auditory issues, there could be peripheral neuropathy issues. So there are a lot of, I don't know of any attempts to correlate especially in large scale studies, HHIE performance with other than pure tone audiometry. It's that same problem of, and in the large scale studies, they're trying to get large volume of data. They can't do large numbers of measures at the same time, especially in just one sensory domain. So yeah, I have no doubt that there probably are other and maybe even other auditory factors that contribute. And I didn't get to what the implications are for having a poor auditory wellness category, but it doesn't mean it has to be hearing aids. It could be that something is recommended along the lines of almost like a pocket talker type device or FM system to improve the signal to noise ratio. If their primary complaint is sitting at home in front of the TV and other people don't like the volume, there are other ways you can deal with that other than a hearing aid. And there are lots of other technologies available besides hearing aids that improve the signal to noise ratio. And I don't know of any group, even normal hearing young adults, where making the signal to noise ratio better is a bad thing. So if you wanted to guess, other than providing gain in a hearing aid to compensate for the hearing loss, the universal thing that you could do for everybody would be use a directional mic with no gain, for example. We'll probably use noise reduction. That's what a lot of Bose, other headsets do, is they cancel, because everybody can benefit from reduced background noise. So there are strategies you could take that would work regardless of what the residual mechanisms are, but I'm sure that some of them are more complicated auditory problems beyond the audiogram, and sometimes it has nothing to do with hearing at all.
Thanks, Larry. Being mindful of time, I'm going to ask one last question, then we'll close up. So this question is specific around the HHIE being a scale that was developed actually many decades ago now. and the concern that some of the items may be a bit dated in contemporary era, but we still keep on using it. Any thoughts about options to potentially update or basically update the items to make it more contemporary, or would that not be a good idea?
I don't know off the top of my head how many are outdated in that sense, but there have been at least a couple publications, including Judy Dubnow's group, talked about, they call it the RHHI, Relative Hearing Handicap Index, I think. R might not be right, but anyway, it's a revised, I think, revised hearing handicap index, but it did a kind of more modern contemporary psychometric analysis and found 18 of the 25 items were the most informative. You don't need all 25, you just need 18. The screener is still 10. But yeah, so there have been attempts to improve it, to shorten it, but they've not been related to changing the content per se, or changing the content because it's outdated. Now, there are other metrics. I mean, there are lots of other tests, surveys that have been developed. One of my constraints was I didn't feel comfortable presenting an argument if it was based on 50 people or 112 people, but if you want to get into the hundreds and thousands of cases to have a better idea what's going on, HHIES in particular had by far the greatest volume of data available. But yeah, it doesn't mean it's the final answer or the only answer by any means.
Thanks, Larry. So I wanted to note now it's 12:59. We're just short of the 1 p.m. hour. I know there's some other items, unfortunately, we couldn't get to. But Larry, I want to first of all thank you again for taking the time. I know virtual seminars are always a little awkward for speakers sometimes to get used to, but I think we're all getting there. And I think just as a testament, I think, Larry, we had over 85 people join your seminar today on relatively short notice, given we announced it a couple of weeks ago. So I want to thank you again. This was a huge draw. And I want to encourage all of you on the call today for interested in our later seminars, please go ahead and join. You can find us on the website and how to register for those, as well as the Cochlear Center Research Day. Thank you again, Larry. You'll be, for the trainees on the call, please go 15 minutes, go ahead and switch over to the other call room, and Dr. Humes will join you there as well shortly.
Okay, thanks very much. I'll see the other group here in a minute. Thank you. Bye-bye.